All right, well, anyway, welcome to this webinar. If you guys have questions over going through this, that's what we're here for. Be sure and interject, and we'll do the best we can to answer those questions as we go through it, both here and online. So the purpose of this presentation is quite simple. Introduce the Implant One implant system, explain why it's been developed, its relevance to the clinician, laboratory technician, and most importantly, the patients that we all serve. The implant system is valuable and capable of solving almost any clinical problem that's out there. So that is what we had in our minds when we developed this system, and I think it has some uniquenesses that are significant in the industry. So I hope to explain how the system works, how it solves some long-term implant challenges, because we're all aware that there are plenty of challenges out there in the implant world. All right, so features and benefits. Implant One is a tapered implant system, and when I say tapered, I don't mean the external part of the implant. Tapered implant systems are taken off in the North American market now. They've been in Europe for a good long time, probably 30 years. But in the North American market, when I say a tapered implant system, I'm talking about the internal taper. The connection is different, and if you look at the cutout of these two implants, there's an aggressively threaded implant on the left and a less aggressively threaded implant on the right, color-coded based on platform diameters. But the internal taper is obviously at the top of the implant, and the orientation of the implant is different than most hexed implant systems out there. The orientation is there, but it's down inside the implant. So that is some of the distinct features of a tapered type implant conical connection. All right, so this implant's made in the US. It's some of the people that are here in the audience today took a tour of this manufacturing facility. It's a brand new facility in Sparta, about 25 miles from here. And basically we're involved in making dental and medical devices for ourselves and other companies. So that is the machining and manufacturing center that produces the implants that we're going to talk about today. All right, let's first talk about what Implant One is not. It's not a knockoff system. And what I mean by that is there's no component parts on anybody else's systems that will fit in this connection. So if you have the idea that you can use somebody else's system to restore this implant, it's not a knockoff system, so that would never work. The connection is totally different. So it's not compatible with any other system. It's not a 40-year-old system or old technology repackaged. And what I mean by that, a lot of implant companies now, they're copying other implant systems and putting on the market as a new system, but they're really copies of other systems. So I just don't want people to make the mistake to think that any restorative components will fit our system coming from somewhere else, because they just simply won't. All right, what is Implant One? Features and benefits. It is a standalone system. We've covered that already. A system that provides solutions to many clinical challenges. When we developed this system, that was really what, from a clinical side, from my perspective as a dentist, what we were trying to accomplish is to solve some of the challenges that we see both from this surgical and restorative side. So that was the focus of the design. It's a superior system to many antiquated systems on the market today. Everything changes. As things change, improvements are usually made. There are a lot of, I wouldn't say bad systems on the market, they're just antiquated systems, old systems that haven't evolved over time. So again, it's not a system that's been out there for years and years. It is value added, cost effective. It's an implant option for clinicians and dental technicians that is more cost effective than some of the major 5 implant companies, for example. I personally think the day of the $500 implant or the $300 abutment's kind of gone. So we understand that is changing. It is a robust system. It can be used effectively in any clinical situation. If an implant's needed in a clinical case, it has enough ability, I think, to solve any clinical situation. It is a very digitally driven implant system, probably more digitally driven than probably any other system out there. Anybody, Patrick, if you want to interject, you certainly can at any point. But it is a digitally driven system, and that's what we use through our clinical practice here all the time. The biggest change with this type of system, a tapered implant system, is designed to be placed at crest or below crest. And that's the biggest confusion, I think, that has to be looked at when you're looking at systems, what their capabilities are, what it's like to restore that implant, what changes in the restorative process, because there are certainly some changes. It's not a more difficult system to restore, but it's certainly a different system to restore than your standard platforms your platform switched implants are different than your standard hexed implant systems. So we'll cover that in detail as we go through the presentation. So what Implant One system is, so why Implant One? What problems are solved by this system? I thought I would first talk about the problems that are solved from the clinical side and from the patient side, and then we'll move into the laboratory side when we get through the design of the implant, what it was designed to accomplish. So let's talk first about pre-laboratory. What does it do for the patient and the clinician? So in the last 25 years, implant dentistry has changed dramatically. We're all well aware of that. Things evolved. We talked about that a bit already. Processes change, technology advances, digital advancements like CBCTs, treatment planning software, digital impression, CAD and CAM software. Obviously, you're all very familiar with all the changes that are out there. But having said that, there's still significant challenges that need to be addressed on a day-to-day basis, both in the laboratory and on the clinical side. And we'll talk about some of those major challenges that aren't going to go away with any system. If you look at the clinical side of implant dentistry, and I'm sure you see this in the laboratory, those are the three main challenges that we as dentists and you as technicians run into every day. Implant placement control. I've been in enough laboratories to know that you all suffer from the same problem we suffer from clinically. Implants are placed everywhere in places they shouldn't be placed, and undersized and oversized, and if you're looking for a mess, implant dentistry's got a solution for a mess. They're out there. So again, I think everybody's keenly aware of the issues that we run into. From the laboratory side, you're probably not so keenly aware of what we see clinically, and what we see clinically is a tremendous amount of bone loss around implants. It's not a new problem. It's a problem that's been around as long as implants have been around. It is by far the #1 issue that we as clinicians deal with every day, and we as clinicians many times come up with reasons why it happens, and we're going to talk about some of those reasons that I think are valid and some that are really overblown. Because again, at the end of the day, we're a team. If we place an implant poorly, it's restored poorly. I don't care whose hands it's in. If we place an implant well and it loses significant bone over time, it's a failed case over time, and nobody wins in that case, so we're looking for a solution there. But bone loss over time on implants is by far the biggest patient clinical challenge that exists in implant dentistry today. And again, this system was designed mostly, honestly, to solve that problem if we could. That was the biggest concern that I had when we were working at developing a different system. All right, so if you look at bone loss, and this again from a clinical side, and I apologize, I don't want to bore you with the details of the clinical side, but obviously you're a key component of the clinical side. According to the literature and all these studies that are done, somewhere between 10 and 40% of implants that are placed have bone loss, and some very significant bone loss. I hear all the time when I'm out listening to presentations that implants are 90-95% successful. Well, what's your idea of success? Is it an implant that has bone loss? Well, okay, if you can accept that as a contraindication or accept that as a challenge, then I suppose you could be 90-95% successful if that means the implants don't fall out of somebody's head. But 40% is a big number. If it is 40% of implants that are placed have significant bone loss, that's a real patient problem that has to be looked at, and I think looked at honestly. So implant success in my mind, if you're looking at extreme success, means that you don't have bone loss around the implant over time. All right, so long-term bone and tissue health, let's just cover it quickly. Biggest challenge in the implant dentistry is that. Biggest success killer in a modern implant practice is that. Etiology is quite controversial in the industry, but the challenge is real. So again, if you're talking about bone loss, is retained cement around implant abutment margins the biggest challenge out there? Is it the reason is it the antichrist, quite frankly, of implant dentistry? I tend to think it's not, because when I cement crowns, I'm not always great at removing cement on crowns, and I don't see significant bone loss around natural teeth that are cemented with the same cement that I use on implant restorations. That's the latest thing out there. There's a ton of mental masturbation about cement and what it does to implants and how it's magically toxic on titanium but not on teeth. It's just not reality. Because we think it's reality, because the industry has a solution to a problem now they think is cement, screw-retained crowns are becoming very popular again. I don't have a problem with screw-retained crowns. They are retrievable. They do make a case more easily solved if issues come up, if you can take the crown off. But they're really going back to screw-retained crowns from the dental side because everybody's afraid of cement these days. We've heard about dieback to the first, second, third thread. We've heard about it for 50 years. And cement is a new version of why we have bone loss. All right, so bone and tissue are lost around implants and teeth for two main reasons. Biomechanically, you're well aware of that in the laboratory. If you put a small implant in or you have a small tooth and a big crown, something usually breaks down. So that's the biomechanical forces that we deal with clinically every day that you deal with in the laboratory. And bacteria we deal with in the mouth, and bacteria is what is really the issues that most patients have. If you have periodontal disease or an abscess tooth or decay on a tooth, it's all bacteria-driven issues. So those, as from the dental side, from the clinical side, are the two things that we would want to mitigate if we were going to place an implant in that environment. So most dentists, really good dentists, have a pretty good handle on how to effectively handle biomechanics and bacteria, and that's really what we're charged to do. Biomechanics, these are just numbers that are taken out of the literature. If you think about how much force is put on your dental implants, your restorations, in the anterior teeth it's about 220 newtons, in the posterior teeth it's about 880 newtons. And people always ask me, well, how much is that? And I go, I don't know. Put your finger between your teeth and bite hard. That's a lot of force. That's what 880 newtons feels like, or 220 newtons, whatever the case may be. But it is a significant amount of force. You can crack ice with your teeth, all those kind of things. So you can see why, if any mechanical thing is put in the mouth, it goes under significant load. And everything has to hold up to that load, whether it's bone or implants or crowns or whatever it might be. And destructive bites are destructive bites. So if you look at a clinical problem, for example, we as dentists do a really good job of handling these fractures up on the crown of the tooth. So if we have a fractured tooth above the gum line, what do? A filling, a restoration, inlay, onlay, crown, easily solvable. What we have no solution for is fractures in the roots of teeth. So again, I'm trying to make a point here. We'll get to implants here in a minute. But we all know if we have a fractured root of a tooth, we do what to the tooth? We always take it out without exception, because there is no solution for a fracture in the bone. And that's the point I'm trying to make. Consider or think about fractures in the bone. What that means is extraction and replacement with something. So if you look at this clinical slide, this is a fracture in the root of a tooth. What we see clinically is bone that's at adequate height. You have a post in the tooth fractured at the apex of the post. That's usually how it works. It's a pretty good lever arm, and if you get a fracture, then you see additional bone loss over time. That makes sense. So we have a fracture in the bone, tooth has to be extracted. What happens when you have occlusal forces that are excessive? Well, you get fractures at the roots of the teeth. It's not toothbrush abrasion, it's lateral forces on natural teeth. We got a whole lot of solutions from a laboratory side about how to fix that. We could put a bonding on there. Well, they popped the bonding off because they haven't solved the occlusal problems. We can put a crown over there. You can prep it down to the tissue. But you can see in this case here, the bone's going away because of the biomechanical forces, and part of the tooth structure is going away for that same reason. Imagine putting an implant in that same environment. You're going to have the same lateral forces and same destructive forces. So oversize the implant, undersize the restoration is the things that we do clinically. So all of this relates to the clinical side and the restorative side as well. But forces are a problem. And when we get a fracture like this, it's not uncommon when you take the tooth out, you have bone loss down to the fracture. It's a biomechanical fracture followed by a bacterial invasion. That's really what happens in the mouth. Okay, so how does this relate to implants? What's the diagnosis here? Well, based on what I just said, it's probably a fractured root. And it's exactly what it turns out. We can't prove it from the x-ray, but if you watch this thing long enough, you'll see here's the fracture. And you also see the fracture, you get biomechanical fracture followed by a bacterial invasion. Just because this is a tooth and it's not an implant, the rules don't change. So that's the point I'm trying to make. If we replace this tooth with an implant, the same bacteria, the same situation is in the mouth. And that's what, again, what we tried to address with this implant system. We'll get to it later. But you can obviously see the fracture causes bone loss. It doesn't happen some of the time. It's 100% of the time without exception. All right, so let's talk about implants. The standard implants, the implants that were developed 30, 40, 50 years ago, most of those implants are what we call a hex-based system. And what I mean by a hex-based system, the abutment connects to the implant in a hex, and every technician on planet Earth understands that. The difference between this implant and the current implants are where the hex is. This hex is up on top. So when you have 6 sides going into 6 sides, you have to build some clearance into that connection. So that clearance is what we call potentially a place for a micro gap or micro movement of the connection. So because you have a hexed implant or a hexed abutment going into a hexed implant, there is some movement under load, and that movement is called a micro gap, and it opens and closes, and you've all seen broken screws. Well, if you flex a wire long enough, it'll break. If you flex a screw long enough, it'll potentially break. So occlusal forces dictate how much that screw flexes and how long it lasts. So again, not something you don't all already aware of. Well, there was a researcher in Germany that did a study on 200 newtons of force. Remember we talked about posterior teeth having 800 newtons of torque. So if you look at an implant, for example, and you put that implant under load at 200 newtons, which is a reasonable force in the mouth, what happens to the implant? This is a micro movement with a hex. So under exposure radiation, this is what the implant abutment looks like under no load. And this is what that implant abutment junction looks like on a hexed implant under 200 newtons of force at a 30-degree angle. Because the teeth in the mouth, the implants in the mouth, they're not straight up and down. They do take some lateral forces. So this looks closed. There's your micro gap. There's the opening. So just on this slide alone, I will tell you that every implant company on planet Earth that makes a hexed implant says you should never place them below the crest of bone. But we as clinicians do it all the time because we're worried about emergence profile and tissue profiles and all those kind of things that you in the laboratory also worry about. So we cheat. We place it at bone crest or slightly below, and when we do that, we run into the issues that I'm about to show you. So this high-resolution X-ray device at 0 newtons of force is closed. That's 50 newtons. It's a lot less than 800 newtons. Understand? That's 100 newtons of force. What I want you to understand is that looks a hell of a lot like that. And if that causes bone loss every time it's in bone, that's why the implant companies say never put this below the crest of bone. But it's not just below the crest of bone. This is where the bacteria seeps in that area. So you got a micro pump moving bacteria in and out of the thing. So the hexed implants, they're not bad implants. They're just really outdated implants. So bone loss is a significant problem. We know if we have a fractured tooth, we have bone loss. We know if we replace a fractured tooth with a fractured implant, use it inappropriately, we just replaced a fractured tooth with a fractured implant, we're going to have the same problems. That might have more to do with bone loss than what cement you use to glue these things together, because the cement really doesn't seal that up. It's above that connection. All right, so again, hexed implants are designed to be placed at crest, above crest if they're polished, and never below crest. So that is the point we're trying to make. The micro gap issue is on every hexed implant system that's out there. So let's look at this, what the German researcher did. This is an implant. I'm not here to beat up implant system. I'm just showing you old technology so you fully understand it. This is the best kept secret in implant dentistry. Most clinicians on planet Earth have never been exposed to this understanding, and if they would change what they're doing. But anyway, this is the implant that Sullivan Shine sells now. It's Camelog implant. But look at the implant abutment connection under load, and look what it does. So under 200 newtons of force at 30-degree angle, that's what it does. And this is a Straumann implant. And again, I'm not here to beat up these companies. I'm just saying this is old technology. Here is the Dentsply implant. Look what that thing does under load. And we'll get to the point here in a minute. Another implant. You see that micro gap is significant. If a fractured tooth causes you trouble, don't put it in bone. That makes sense. That's all I'm trying to make. Well, this researcher, he pretty much attacked every implant company on planet Earth. He's still alive. I'm not sure how. But anyway, he had put synthetic saliva around the implant abutment junction and tested that. If you consider the mouth full of bacteria, full of saliva, full of all the bugs that we carry around every day, imagine these bugs now moving into that implant abutment junction. You see what happens when you open that up. That's why when you take implants, abutments off of implants, they smell like heck. It's the bacteria that gets trapped inside that implant. You've probably noticed it in the laboratory. Abutments come into the laboratory and they kind of smell nasty. It's because they're impregnated with a lot of bacteria. All right, so again, well-researched, well-studied, and this is just some of the research. It's a bacterial seal that's the problem. If it's not sealed, it's a cracked tooth. So the pumping effect happens all day long, and I'm not going to bore you with the details. I'm just trying to make a point. When I first realized this was about 15 years ago. Europe has had these type of implants, these different implants, for almost 20 years. They're new in America in the last 5 or 6 years. So again, let's talk about what's different about the tapered implants versus the hexed implant system. Once I realized I was replacing a lot of fractured teeth with fractured implants, I started to understand why I had significant bone loss around those implants. So if you're going to develop an implant system, why would you develop the same problems everybody else has? So that's the point we're trying to make. These are cases that were in my office. This is significant bone loss around the implants. So this is an implant that I placed many years ago, and I take that back. This is actually not my case. This is a case that came from an oral surgeon. That was placed, good oral surgeon, placed an implant, but you can see what he did. He placed this implant well below the tissue level. So the implant abutment junction is well below where it should be. And because it's well below where it should be, he didn't place it subcrestal, he just placed it in tissue where it's not cleansable. So the point is, because this thing collects bacteria, every time the patient flexes that tooth, the bacteria gets in that crack or that fracture, that connection, and it causes tissue inflammation. And tissue inflammation eventually causes exudate. So this was actually a well-placed implant, just an implant placed where it wasn't appropriately placed. So what was the solution? There is none. You have to take the implant out. So this patient now has a bridge. But my point is, it's a huge challenge in the clinical side of implant dentistry. And again, it's been around for a long time. But that fracture is the same as that fracture. If this fracture is not cleansable, it's a problem. If this fracture, on the other hand, on a hexed implant system, now I will tell you, I placed a lot of Zimmer implants for a lot of years. Some worked out well, some didn't work out so well. The ones that didn't work out so well, I placed like this one. The ones that worked out well were high enough that the patient could brush and floss and keep that connection clean. It's such a simple concept, but it's, again, the best kept secret in implant dentistry. So if you're going to place implants at that depth, because bone sometimes is at that depth, you cannot use a hexed implant system well. It won't be a long-term result. The newer systems you can, because the implant abutment connection is much tighter. All right, so again, driving the point home. This is that Nobel implant under load, and that's what an implant does. So you can see, placed at that level, you got a fractured tooth replacing, or fractured implant replacing a fractured tooth. Both the tooth was lost and the implant was lost for that reason. It's a common thing. This is my case. I placed this implant quite a few years ago. Do you see the bone loss and the destruction on this patient? All right, that's not a ceramic abutment. That is exudate coming out around the implant. And that's a common problem that we see on periodontal involved teeth, and we also see it on implants. So that's a failure that's happening in one of my patients because the implant abutment connection is here and the tissues clear up here. So over time, bone is lost. It hadn't have a damn thing to do with cement, in my opinion. All right, so the problem is bone loss over time. So what's the solution? The solution is a tighter connection. If you can remove the fracture, you can remove the problem. If you don't remove the fracture, the problem cannot go away. So this is the solution to a 50-year-old problem. And it's not dramatically different. The only thing different about it is we've taken the orientation of the implant and moved it here, and it's not up here any longer. Now we have a tapered connection without 6 sides going into 6 sides, a tighter connection, so when this thing goes under load, this space doesn't open up. That's all we've done. And they did it in Europe 25 years ago. So again, it's not a clearance fit anymore. Now it's a press fit or a cone connection. Is there still a micro gap? And the answer is anytime there's 2 pieces, there's a micro gap, but the micro gap is smaller than the size of oral bacteria. So that is the difference. So again, you can imagine now, if this is not a fracture, now you can place this at many different levels clinically. And I'm making a point, when we get to the restorative side, restoring these implants, because they're at crest or below, is different than a standard implant system. So I'm just making the case of why it's important so you understand that process. So the newest technologies, everything evolves. The Morris taper is not a new technology. It's relatively new in the US market, but again, it's been in Europe over 30 years. Ankylose and Bicon and those implants have been out there a long time, and those are tapered connections as well. All right, so in the US market, Implant One now, for example, is made in the US. This is the Implant One. Now you understand the tapered connection, the orientation down here. These connections are just much tighter than the standard hex connection. Under load, they don't open up. And let me show you what that looks like under force. So same researcher did some research on these implants, and you don't see a micro gap opening up with this type of implant system. That's the only difference between these systems. So here's your conical connection under load. And again, you don't see the opening or the fracture that you see in the standard hex implants. All right, so again, synthetic saliva in there would not penetrate through that opening, but you can see none of this opens up. Well, some people say, well, yeah, you're looking at metal on metal. You can turn up enough exposure, you can see through anything. So it's been well researched by this German researcher. So here's your synthetic saliva now in this type of connection, and you won't see in this case where the saliva is moving down inside the implant. So again, the concept is solid. It's well researched. It's not new data. It's been out there for a long time. It's just new to most dental clinicians out there. Again, well researched. This is your standard hexed implant. And you can see the micro gap there is about 60 microns. Oral bacteria somewhere between 2 and 10 microns on average. So if it's 60, you got a pretty good opening in there. For the Leone system, this is the Italian system. The micro gap in that is less than 1 micron. So there is a gap. It's just smaller than bacteria. So you don't get that pumping effect of bacteria in and out of the connection. And again, when you look at it under microscope, these things are pretty well sealed up. And again, that's why it works. And here's the research that's been out there, again, for a long time. Most of it's European research because they're, again, ahead of us in that point. All right, so let's look at the solution. We talked about the problem. Here's the solution. This is a German solution. This happens to be the ankylosing implant. Here's our Italian solution. This happens to be a Leone implant. Both of these systems are designed to be placed subcrestal. This has been out there for 30 years. It had some issues with fracture issues and whatnot. It was the first one here that was a screw retained system. It got beat up quite a bit when it came to the US market because it had fracture issues. All those things are addressed now by some of the newer systems that are out there. And this is the US system, the Implant One system that's made here in Wisconsin. So again, we beefed up the connection here so we don't have the fracture issues that Ankylos had, for example, but we learned from their mistakes. And that's the idea that things evolve, you have to evolve with them. And again, this is a system that we're talking about working with Apex on today. So the difference between these systems now, for example, you can place these implants now below the crest of bone and see the bone stay healthy for years and years and years. So again, when you take off an implant abutment connection now, you look at tissue that's healthy. I always say to clinicians when I'm doing a lecture, if tissue bleeds, it's not healthy. So if you take something off of an implant and the tissue's bleeding, understand you got a problem. Because healthy tissue doesn't bleed. And again, you can place implants now at crest or below crest. Bone gets very narrow. With the old Hexed implant systems, for example, if you wanted to restore this case, the clinician would have to grind the bone down to this point and down to this point. And if you grind the bone down that far, what are you going to see? Black triangles between the teeth, long crowns, all those things that we don't want to see. And that's why we cheated by placing those implants subcrestal. So all this relates to the surgical side, the restorative side. It doesn't go away. This is a patient, my patient. This is the x-ray I showed you before. Losing bone with I think this was a Nobel implant that I placed years ago. This is an implant now placed below the crest. This was the ankylosing implant. And this, you can see the health of this environment here. So we're not the only ones out there that understand that this is a problem. We're just the latest one out there trying to correct the problem. So bone loss over time, same patient, same environment, losing bone significantly, not losing bone over time. So it's a big deal. All right, in the end, what are we after? I don't care if you're the dentist, the patient, or the clinician, or the laboratory technician. This is what we're looking for. We're looking for a natural tooth that looks like a tooth. And we're looking for something that looks like a tooth on this high smile line that's going to look like a tooth for the next 50 years. That's really what we're after. And you cannot do this kind of work with the older technology. That's the difference. So again, that's the reason it's not a repackaged, resurfaced old technology is why we made the change. Make sense? All right, so you get a case like this. The literature will tell you can't place implants right next to each other, close to each other. There's an implant for every tooth in this case, and this case is 15 years old. So again, because it's a different connection, it's a platform switch, it's a tighter connection, you can do things and have healthy tissue for many years. So it's a 13-year-old clinical case. And we didn't do anything surgically. We didn't really do anything different restoratively. We just placed an implant that has a better connection. What we run into all the time clinically is a case like this. We have a lot of missing bone. This in the past was a case where you couldn't place an implant, you'd have to graft and come back later because you're always worried about where that case would settle. You can't place the implant below the crest. You can see we went well subcrestal here. We're going to assume when we graft this, we're not going to get complete bone healing, but we're going to get enough bone healing that the implant will be embedded in bone. And sometimes these implants get buried in bone, and that is another challenge for the clinician to unbury them. But these things we can do now, we couldn't do 10 years ago. So cases are done much quicker now because we have the ability to do things clinically that we couldn't do before. All right, so how does the Implant One system solve problems and changes that happen in the laboratory? How does it affect what happens in the laboratory? And we'll spend the rest of the time talking now about that. All right, so this is our implant system. Let's just introduce you to the system so you'll understand it, at least understand the highlights of the system. There's an aggressively threaded implant and a less aggressively threaded implant. The less aggressively threaded implant has some micro threads, and there's some reason behind that. And the aggressively threaded implants are designed for poor bone density and immediate extraction cases. These implants that can be placed subcrestal are the cases that we use these implants almost all the time now. We take a tooth out, put an implant in the same day. In the past, I did that maybe 10% of the time. We pretty much do that 95% of the time now. If we can get the implant stable, oriented correctly, we don't wait 4 months and graft, come back 4 months, put the implant in. We kind of do it now on a day-to-day basis. It's pretty rare that I take a tooth out and don't put an implant in that day. The only reason I wouldn't is I couldn't get the implant oriented correctly or stabilized. Otherwise, it goes in. All right, so that's the implant itself. They're color coded. So this is the 300 series, this is the 400 series, and the 500 series. A lot of implant companies now are saying, well, let's just have one connection. Well, if you're going to just have one connection, you're going to have fracture issues. There's no way to get around it. Does it make the restorative process simpler? And the answer is it sure does, because you got one connection. But when you put the same connection on a 3.5 implant as you do on a 5.5 implant, if there's a screw going through that titanium, you're going to have a fracture issue when you put a big crown on top of it. Anybody that understands biomechanics understands that. We're trying to make it easy for the dentist, but it isn't good for the patient long term if things fracture in the end. So we know strength has to be there on these larger implants. So bigger the implant, bigger the connection, more force you're going to apply to that implant. So that's the concept. The lengths are 8, 10, and 12, 8, 10, 12, and 14 millimeters in length. All right, so for your standard type implants, they come in different lengths, different diameters, and I'm not going to bore you with details here, but it's a pretty robust system. You can pretty much pick an implant for any need that you would need for this particular case. So they have the standard thread implants and the wide thread implants. Standard threads are 3, 5, 4, 4, 5, 5, and 5.5. So probably more diameters than it's really needed, but it gives us some flexibility. I tell doctors all the time, if you only want 3 diameters, then pick the 3 you like and forget about the rest of them. It doesn't make it more difficult, just ignore that they're there. And the wide thread implants are 4.1, 4, 5, 5, 5, and 6, 5. And they're pretty aggressively threaded implants, as you can see. All right, restorative abutment options. From a restorative side, I'll get into how they restore differently, but the connections, the things they attach to are very similar to every other system you've ever used. For example, you have your tie base abutments. Everybody understands what a tie base is. Well, this is the Implant One tie base. It just connects differently than your standard hexed implant tie bases, but once you get it connected, they're the same from that point on. Would that make sense, Patrick?
Okay. It does. Can I point something else out?
Sure.
Something different about our system is that because it's potentially an implant that can be placed subcrestal, you don't want to go with the stock 0.5 millimeter platform height on a tie base. So we have different height tie bases. So we have a 0.5 millimeter, we have a 1 millimeter, and we have a 2 millimeter for those occasions where something is placed subcrestal. And I want to point something else out. The nomenclature for a tie base being a 2 millimeter platform height. At some point way back when, it was decided that a 0.5 with most implant systems was actually 0. So if you hear that we have a 2 millimeter platform height on a tie base, that tie base platform height is actually 2.5 millimeters high. But you have options there. So if something is placed subcrestal, a large problem that you're going to run into in a laboratory is creating a scenario where the restorative technician is creating something that is going to create a bone collision. And if you don't know what a bone collision is, I think Dr. Malin will touch on some tools that we have to address that.
Right. I will, because again, if you go subcrestal, common sense will tell you, well, now you're working in bone, not just tissue, things change. And we'll show you how to handle those changes. So the conical abutment, we're probably going to change the nomenclature there. That's really a multi-unit abutment. So everybody calls them a multi-unit abutment, and I think we'll change that in the catalogs here as we go along. But you're all familiar with those. They come in 0.5 cuff heights up to 5 millimeters in cuff height. And then we have the angled, we'll call them conical or multi-unit abutments as well. I think they're 15, and this shows 15 degrees. They're actually 25-degree angled conicals out available now as well. You have your standard abutments that, everybody has standard abutments. Personally, in clinical practice, it's been a long time since I've used a standard anything. So pretty much is all patient-specific abutments, but they're available if clinicians want them both in straight and angled. And they go anywhere from 0.5 to 5 millimeters in cuff heights as well. So again, because we're going subgingival, subcrestal, the connections sometimes have to be longer because we're coming from a lower place to restore that case. So again, all these are in the catalog. These are just pages that I basically took out of the catalog. Your custom abutments, pre-machined blanks that the laboratory can use to make patient-specific titanium abutments are there to be used in all 3 different connection diameters. So those are out there. Your straight abutments are used. Straight abutments are placed in narrow areas like in the lower central incisors where you have very little space. Sometimes those real narrow abutments are required just to fill the space. So those are out there. Temporary abutments are used, again, just as they're described. put in for a temporary restoration, and then down the road replace it with a permanent restoration. Wide post abutments, they're out there. Again, to be honest with you, I in my practice use very few of these. Most of them come out of the laboratory as a patient-specific whatever. And the solid abutments are there too. So again, that's a one-piece abutment basically that can be screwed in and modified in the mouth if the doctor prefers something like that. Denture attachments, ball abutments, abutment type of attachments come in different lengths as well, so they're available, and everybody has those in their system. Denture retaining abutment works, and again, we have all those available as well, so your standard type denture attachments are in this system as well. Again, they're all the same once they're in. It's just one's at the top of them kind of matches everything else that you're used to working with. The healing caps, again, because we're coming from a lower profile sometimes in your standard implants, we have pretty tall healing caps. Some of them are 7 millimeters high, and you need them sometimes when we're going subgingival, subcrestal. And again, we'll talk about bone collisions and how to handle those things as well, but they come in different lengths and different diameters, so pretty robust system in terms of that, but we're all well aware of a circular healing cap gives you a circular emergence profile, and it's not what you're looking for, but that is what is taken off the shelf. So obviously there are ways to build emergence profiles differently than round abutments, and you're all well aware of those. Every system out there has that challenge, and this one will as well. Impression posts. Impression posts are flat on a flat, so radiographically, like any other system, when you put it in there, you want to x-ray that impression post, make sure it's fully seated, and if it is, then move forward with the impression. They have the standard closed tray impression posts. Open tray impression posts are available. These are my heavy hitters if I'm taking a standard impression. If you're doing multiple implants on top, all the laboratories prefer an open tray impression for all the obvious reasons, so those are available as well. And then the analogs that fit all those. You want to talk a minute about the analogs, Patrick?
Sure. And if I can get a picture from up above on the table. So we all know that in contacting any other implant company, if you want to order an analog, sometimes there's confusion. Which analog do I need? They have long analogs, short analogs, digital analogs. What we tried to do is really simplify the process. We have one analog, and this analog will work with old traditional analog processes, and it will work with new digital techniques. We spent a good deal of time to make sure we can add some value with it. Every laboratory has spent a considerable amount of time coming up with a workaround to either glue in an analog or come up with some unorthodox means to seat it. You're never sure if it's completely seated. So here's an example of a printed model that we have we have what we call a verification pin. When the analog is completely seated, there is a pin that will go through sideways through the model and lock and absolutely confirm within microns that analog is completely seated. When we designed our libraries for 3Shapes and exocad, we put a 29 micron gap for the cavity that is created for the analog, so there should be no potential for operator error with creating slop by trying to make the analog cavity larger. And another little trick, we have I'm going to call it a through bore on the bottom of the analog. So if you want to, you can take a standard handpiece shank bit and simply press the analog out. You've just retrieved it. It's not marred up or mauled, and you can use it on your next case. If you choose to not send the models out, you can retain these analogs in-house. So that's what I would like to point out about the analogs.
All right, thank you. What he said. All right, so those are the analogs, and again, I think it's awesome because it's just one analog that fits everything, basically, is where we're at with this analog. And then we have the conical analogs for your screw retain whatevers. Digital impression options. I said earlier, we're digitally driven. This implant system, I think, is more digitally driven than most. We have obviously the 300, the 400, and the 500 digital analogs, and I will tell you from intraorally, these things are pretty darn easy to pick up and seem to be accurate You want to add anything there?
Most laboratory technicians are familiar with analogs that are basically going to look like a cylinder with a flat on them. Most doctors that buy new scanners are very motivated to use them, but aren't necessarily aware of something we call data stacking. And they can go over the top of an analog too many times and basically create a false height associated with the implant. So to circumvent that, we've created a bevel on the top of the analog and a series of additional geometries that guarantee that that is lined up correctly in 3-shape and exocad.
And again, pretty easy to use. And again, let me go back here. These are a flat on a flat, so from a radiographic standpoint, again, if you want to always worry about bone collisions, but we want to make sure things are fully seated. So an X-ray should be taken before this is digitized, just to verify that it is fully seated in the mouth. So working with your clinicians, if they start to use a subcrestal implant, that's something you'll have to help them understand. Our digital approach, so just a typical of how it would work in clinical practice, we have a patient that has an Implant One implant placed, healing cap for 6 weeks, I think in this case. We're putting on the implant stability quotient pin, and we're testing it with radio waves to find out how stable the implant is. So when we get above 70, we know we're ready to restore. So the restorative process varies depending on the bone density we put it into and whatnot, but we're storing implant cases pretty quickly now with this digital technology that tells us when these things are integrated. All right, so a patient-specific abutment was made in this case, so this would be your patient-specific abutment. I don't know what diameter implant that was, but it would be one of those 3 series implants. So Patrick then designed and milled patient-specific abutment and a crown to go over the top of it. So pretty typical of what we would see with any clinical case. You also see in this clinical slide now here, the radiographic slide is obviously was placed subcrestal. We do worry about bone collisions here, so we're going to talk about bone profilers in a minute, how the clinician will handle the bone that's around the implant if it's in the way. But you're building from a lower profile than if your implant was up here on your standard Hexed implant. So there are potential to have those bone collisions where you don't have with, in your standard implant cases, you worry about emergence profile, but you're only talking about tissue. Now with these type of implants, you're talking about tissue and bone that has to be managed and handled. So there would be your typical case. Again, why wouldn't we use a standard abutment? Because this is just a better abutment, better emergence profile, better everything. Okay, so in 2020, things are changing, things are different, new innovations, new processes. In clinical practice, this is what's out there. We're working on surgical guides that are inexpensive to do a single case surgical guide. We're not going to get into that today. But potentially in clinical practice now, we could have a surgical guide made, place the implant, and restore it in 2 appointments. We could do surgery, take a digital impression the day we do surgery, cement the crown 4 weeks, 5 weeks, 6 weeks, 8 weeks, whatever the case may be. So just really rapidly moving patients through, predictably through the process, and it's all digitally driven today. So that's what you're seeing here. You're seeing a guided surgery done, maybe 1 appointment to get ready to do the guided surgery, 1 appointment to place the implant and take your final impressions day of surgery in a guided process, and then placing restorations 6 weeks later, I think in this case. So we're looking at a ISQ number of 75 at 6 weeks, so we're ready to place the implant. So again, understand we placed the implant, did the digital impression, waiting the appropriate time to seat the crown, but we're doing all that in basically 2 appointments, which is remarkably different than the way we used to do things. So you can see also we're patient-specific abutment. This is a hybrid type abutment now, and your final restoration is all verified and seated. All right, so from the surgical side, there are surgical kits and drill kits. The kits for this system are small. And the reason we did that is we have 4 kits: surgical kit, restorative kit, drill kit. And the reason we like that, or I like that, is when you want to do a case, you can sterilize small containers and not have all these parts and pieces going through sterilization over and over again. So that the small kits were made by design. So this surgical kit and this drill kit will place every implant that we own, or that we would use in clinical practice. With this example, we're placing 2 drills and placing 4 different implants. So again, it doesn't take a lot of drills. You've got 2 drills. If you're sequencing, you're drilling pilot drill, final drill for these 4 implants, and it's laid out here. Then you go to the next drill for the next implant. And if you want to place these 2 implants, you'd go 1 more drill, so it kind of sequences through that. All that's on the surgical kit is pretty self-explanatory. All right, and the restorative kits are out there. And again, the doctor to do the implant really needs 4 kits. They need a surgical kit, restorative kit, a bone profiler kit, and wouldn't necessarily need a restorative kit, but I recommend they have it. And what was the 4th one?
We were working on a laboratory kit.
We're working on a laboratory kit. And a laboratory kit basically would be very few parts. You know, it's an 050 hex is the screw in the implant, and a removal tool to remove the abutment, and we'll get into that here in a minute as well. So it takes very few parts and pieces to keep this thing moving through the laboratory. All right, so subcrestal placement, tissue development, emergence profile, what's the difference restoratively? And this is what you run into in the clinical side and also run into in the laboratory. We talked about this a bit already. If you can imagine this is a standard hexed implant, the standard hexed implant is almost always placed, if it's placed correctly, at crest or above. So when you're developing an emergence profile, you don't have much room to develop it, and it's all soft tissue. What's different with these implants is, well, the bone sometimes is very thin on top, and we used to have to flatten that out to put the implant in. Now we leave the bone thin on top, and we just drive the implant in further. It could be down 1 millimeter, 2 millimeters, maybe 5 millimeters. But again, we're not removing bone height, so we're not removing the tissue and bone profile to the adjacent teeth, so these cases just look better when you're done for that reason. So again, if you're going to go subcrestal, just visually here you can see what happens. You've got to get something to come up out of the bone, and once you're out of the bone, start to develop the emergence profile. So that's why we have different tissue heights. You don't want to remove all the bone that's there. That's really what's giving you your aesthetics. So the idea is we don't want to remove an excess amount of bone. We want to remove enough to get our attachment on there, but not so much that we start to lose the aesthetics of the case. So again, we're building from a lower profile, but you can see also there could be collisions here. If you send this to the laboratory and they think it's a standard hexed implant, you in the laboratory are going to do what? You're going to pick your shortest abutment, because you've been given no information. You're going to pick your shortest abutment, and you're going to put it on here, and you're going to start to build your emergence profile from that point. When you send this back to the clinician, it's not going to seat, because your shortest abutment is going to have bone collision, and they're going to send you back for a remake, and that's why these systems tend to get beat up, because the communication isn't there. If they don't tell you that it's a subcrestally placed implant, and you don't know that, you're going to screw it up, and so is the technician. There's no way of getting around it. So the idea, and what I always propose is, when you put on your impression post, before you do it, oops. I'm going the wrong way, sorry. Hit the wrong button. When the clinician puts on the impression post, they have to take an x-ray to verify it's fully seated. Before they put on their impression post, they ought to measure from the top of the implant to the top of the tissue and tell you what that number is. They also ought to tell you what the number is from the top of the implant to the top of the bone. And if they forget to tell you, they should send you the x-ray that shows you. So there's ways to go around it, but that's what you're going to have to do in the laboratory when they start to use these systems. These systems are going to take over the market. 15 years ago, they were 0% of the North American market. In the last 7, 8 years, they've turned into 15% of the North American market. So they're out there, and they're growing quickly, and I think in 10 years, they're going to be pretty much what's left out there. So it's just a retraining of how to do it. All right, so you understand we're at a different height and a different emergence profile. Some of it's bone now and some of it's tissue. So that's basically what we're looking at. At the end of the day, though, you want a normal emergence profile, and that's easily established. So if you look at this slide, for example, I said this earlier, you need to know, or you'd like to know, what the distance is from this implant to the bone. And you'd also like to know what the distance is from the bone to the top of the tissue. And you can see that visually on an x-ray pretty well, and you can also measure it. So a good clinician will give you that information. And also send you an x-ray of the impression post, whatever impression post they took, send it to the laboratory so the laboratory can understand what you're looking at. So again, from here to here is bone, from here to here is tissue, and that's what you're dealing with these emergence profiles. All right, so this is typically what I would send to Patrick to do the restoration. Here's an implant that doesn't look like it's very subcrestal, but if you look at it in a different view, it's more subcrestal than you think. So x-rays are taken at different angles, they can be a little confusing. What does this tell you? That's the digital impression post, not fully seated. So the clinician, if they did this correctly, would put that in there, take an x-ray just like I did, and say, you know what, this thing isn't seated. If you take your impression here, you have no chance of this thing working, because you've taken it at the wrong position. So again, you have to get this implant impression post down on top of the implant. So you got a flat on a flat. Now you've verified to this point everything's correct. But you can also envision, because we have all this bone to work with, how much easier this is going to be to make this look like a natural tooth that's not longer than the teeth beside it. So that's the concept. All right, so you can see uncover the implant, impression post, verify that you get the thing fully seated. That's not the laboratory technician's responsibility, it's certainly the dentist. So as a laboratory technician, when you start to use these systems, I would require, if need be, that they send you the data so that you know you're not making a crown for the fun of it. Because if they skip that step, it has no chance of working. All right, so here's another typical case. Here is pretty well subcrestally placed implant. Patrick said earlier, you don't want to take the smallest abutment you can make here, the shortest one, and put it in there because you're going to run into bone collisions unless you remove the bone, which can be done. And there are ways for the clinician to remove that bone even after the restoration is made if the wrong abutment potentially was picked. So the clinician just has to understand how to make it work. So that's fully seated. You see a flat on a flat, and your final restoration is fully seated as well. So that would be typically what you see. Bone profiling kit. We talked about bone that was where it shouldn't be, and how do you get rid of it? This is a bone profiling kit, and the bone profiling kit is used to remove that excess of bone. So if you're looking at a bone profiling kit, this is the third kit that we talked about. It has pins that guide these profilers down over the implant. So it could be used at time of uncovery. I keep hitting the wrong button here. It could be used at time of implant uncovering. It could be used at time of restoration placement. So the bone profiler kit is a must with this type of implant system. Without this, your challenges clinically, restoratively are going to be significant. Again, the problem with these implant systems is not that we don't have enough bone like we used to have a problem with. The problem is now sometimes we have too much tissue and too much bone. We got to manage it. We got to get rid of some of that to get the restorations fully seated. But the punch is designed if you're let's just say the implant was placed, the cover screw was put over the implant, the tissue healed over the top. This would be the process of moving this forward. You basically take a biopsy punch, cut a hole in the tissue, get to the top of the implant. Now, if the implant's submerged in bone, you got to remove bone to get to the cover screw. But once you get to the cover screw, you take it off. Once the cover screw is taken off, this guide pin is placed on the implant, and the profilers go down over that guide pin. We'll cut a bone away at whatever profile you want, but not hit the implant. So again, you don't have to go in there with a high speed and a lot of water and blood and everything else and figure out what you're trying to take away. The tool does it for you. That's the concept. All right, so this is your bone profiler that goes over the guide pin, and this bone profiler is made at different diameters. So if you want a wider emergence profile coming up out of the bone, you'd use a wider emergence profile. There's 3 different diameters potentially that the clinician would use to profile that case. All right, so it would look something like this. This case was profiled. So you can see we've removed the bone, potentially took off the cover screw, put the pin on, profiled it, and now we've verified when we put the impression post on that it's fully seated. So this is an x-ray that must be taken, should be taken, both clinically and sent to the laboratory to verify what you're doing. And if they don't send you that, train them to take it. They just got to understand what they're doing. You may understand that some dentists are mechanically challenged. That's a reach, but it's possible. All right, animation, bone profiling thing. So let's look at how that potentially would work. Okay, so there again is a picture of the kit. It's a profiling kit. All the tools you need are in there. It has 3 different diameter profilers. So like we described, remove the cover screw. It's an 050 hex driver. All the screws in this system are 050 hex, whether it be the abutment, the cover screw, whatever. So there's your guide pin, turned in clockwise, still fully seated, and those are basically your 3 profilers that you'd use to remove the bone. And again, it's real simple, it's quick, it takes just seconds. You just have to have the tools to do it. So this rotates at, I don't know, whatever speed you can run it at, 600, 800, 1,000 RPMs is the recommendation. So again, it's just a matter of taking it down. The pin won't let it hit the implant, but it'll take the bone around away from the implant. So you can see now you've got your emergence profile developed. So there's your bone profiler tools that you would use for the system. All right, so again, old version of the impression post was like this. Ooh, I keep hitting the wrong button here, sorry. Old version of the impression post was like this. We've improved that. So with the old version of the impression post, you weren't 100% sure if you had bone in the area, whether this thing was fully seated or not. And that's where all the older systems were used that type of a profiler. Again, so there was always a guess, is this fully seated or not? With the new impression post, in the next slide here, you'll see that we have an impression post that goes down, you have a flat on a flat. So when you're this far subcrestal, like you see in this case, this is your standard placement in the aesthetic zone. And you can imagine in the aesthetic zone, if you get all your titanium down below the tissue and down the bone, how much easier this thing is going to make it look good. You don't have to worry about graying tissue and whatnot, because all your metal is significantly subgingival. So coming off the top of this implant now is going to be a titanium connection with a zirconia core and a zirconia crown, or whatever the case may be. So tissue response is much easier, or tissue aesthetics is much easier than before. So this would be a picture of the implant. This would be a picture of the scan body. We want to do a digital scan on here. Now what do we run into sometimes? This implant's pretty deep, as you can see. Plenty of opportunity to run into bone and adjacent bone doing anything in this case. So we profiled it. We got the digital impression fully seated. Problem was the digital scan body isn't long enough to really pick up all the dynamics of that scan body. So we took that off, and then we went to the standard impression post, which is longer. So in those cases that are deeper, you have an option. So if we would have scanned this one, we wouldn't have been able to scan much of the anatomy because it was down in the tissue. Does that make sense? But you can see, because we profiled it, you could take what potentially would be a very challenging case, and it's simply restored. Let's play devil's advocate. This wasn't sent to you appropriately, and you picked the shortest abutment, and now you can't get it seated. Well, your out is you still got a bone profiler in your office. So you simply take the bone profiler and you profile it until you get it fully seated. So it would be less likely to cause the laboratory a remake. But you can also see, if they send you the x-ray, no one would pick a abutment here, a tissue height that's real short. They should pick one that's slightly longer. It just makes it easier to be restored. All right, so all the challenges that potentially are out there, we've tried to come up with a solution for those challenges. This is unique to this Implant One system. For all of us that have used different implant or different platform tapered implant systems, the challenge, the beauty of the connection is very tight. The disadvantage of that connection is if you ever have to take the abutment off the implant, it's very difficult to do. They just don't come apart easily. So in this iteration of this implant system, now Implant One, there's an abutment removal tool. So you simply take the screw out of the abutment, even if it's 5-6 years down the road, and you can put this abutment removal tool in and remove the abutment easily. Worst case scenario, you break an abutment. Anything that has a screw going through it has a potential of breakage. Any system does. So if you broke an abutment in the past, it's very difficult to get that broken piece out of a tapered implant, regardless of whose implant it was. In this case here, potentially you could remove a broken abutment with this removal tool because of the thread design that was designed in there to bring the abutment out. So that opportunity is there as well. But this is how the abutment removal tool would be used. All right, so again, these implants, they lock in there tightly, and that's the advantage of these implants. So you have to get the screw out. So again, let's assume we're a couple years down the road, and for whatever reason you want to take off the abutment. You simply have to remove the screw first and insert the removal tool, and the abutment will come out quite easily. And how this thing was designed to work is above my pay grade, so I'll just tell you it works. So once the screw's out, and then your extraction of the abutment is quite simple. Simply turn it counterclockwise, and it basically jacks itself off of the implant. So I had experience with ankylose and other implant systems that were tapered implant systems. It's very, very hard to get the abutment off a year or even a week later after it's in place. So that, in a nutshell, is how that works. So I think that's a big advantage over some of the other tapered systems I think that are out there, because it makes it more retrievable. All right, so again, having said all that, if you can do a lot of things with this system, clinicians get to make choices on how they restore a system. This is a case that Patrick and I did just last week. And with this system, we had 12 teeth I think we were going to take out. We scanned this patient. We had final restorations made, and we took the teeth out, put in all these abutments, and an upper and lower full zirconia arch restoration. So the system is robust. It can do pretty much anything. And that's what we did with this case here last week. His teeth came out, implants were placed previously, and you can see we got a lot of tissue contours and whatnot. So it's an 80-year-old man for a full mouth reconstruction. So we took his teeth out, put in the patient-specific abutments, all of them, and cemented the upper and lower restorations over that case. cemented them with temporary cement. Now again, the tissue's going to heal. We're going to pull these off and modify the restorations before we put them in with either long-term temporary cement or permanent cement down the road. So extract in place is what we did. So that's kind of where we're at in implant dentistry. We're not delusional though. With any mechanical system, we know there's some challenges and mistakes that will be made, both from the dental side, the technician side, the patient side. So we're not delusional. We'll know we'll have some issues. The point I'm trying to make is we're a team of people, of dentists, technicians, machinists, manufacturers. If there's a problem, we have a solution. That's the point I'm trying to make. We'll address whatever challenges come up. So for a problem that doesn't exist, we're already looking at, will it be possible for some dentist to over-torque a screw and break it? I think it's possible. So because it's possible, and we know that dentists potentially could do that, or somebody could do that, we know at some point we're going to have a broken screw, because everybody has a broken screw. If you torque a screw with a torque wrench, or the torque wrench is not appropriate, you could break a screw. So we have a solution to a broken screw that we have available as well. And as the system moves forward, if we run into other issues, we'll find a solution for it, is the point I'm trying to make. So this extraction tool is designed to, again, works to remove a screw that's broken down inside an implant. All right, well that is the end of what I had prepared. Thanks for listening, and looking forward to working with all of you.
Thank you.
Thank you.